is a connections between frontal and cerebellum. That's why people with cerebellar atrophy or stroke, they can present with executive problems. Patient with MSA can develop emotional incontinence, which we call it as a pseudobulbar effect. Dysautonomia, and the other type is Parkinsonian syndrome. So we have two types, whether MSA with Parkinsonian syndrome or with cerebellar syndrome. And this is the MRI finding that you would see in the MSA, that in number A you would see the hot crossband sign, and you will also see atrophy of putamen, middle cerebellar, peduncular bones. Treatment, no effective treatment. We just treat symptomatic treatment if needed. The other one is a progressive supranuclear palsy, which is a sporadic occurrence, age 40 and older, a gradual progressions, and symmetric axial oriented and akinet. So he has rigidity. Usually it is axial, symmetrics, and also levodopa resistant, poor responsive to levodopa. So people, they will present it usually with axial rigidity and supranuclear gaze palsy, in addition to early fall or early postural instability. Cognitive profile of PSP, the neuropsychology profile is, as mentioned before, they will come with an executive type problems, which is more common in PSP. Behavioral abnormality, apathy, disinhibition, anxiety, depression, and pseudobulbar palsy. MRI, the usually prominent midbrain atrophy, as you see in A, and also morning glory sign, as you see in MRI B. Treatment, no effective disease or modifying neuroprotective agents. We just go symptomatic treatment. In the corticobasal syndromes, is insidious onset, gradual progressions, at least one cortical symptom, apraxia, loss of cortical sensitivity, alien limb phenomena, and at least one extra pyramidal symptoms, akinesia, rigidity, dystonia, and myoclonus. It has an association, so always when you have a suspicious case of corticobasal syndrome, you have to think about behavioral variant FTD and non-fluent PPA. Also, they are poor responsive to levodopa. This is the MRI where they have parietal lobe atrophy, and it is usually asymmetric. Treatment, no effective treatment. The other category is a frontotemporal dementia, which has a behavioral variant FTD and primary progressive aphasia. We have two types, non-fluent PPA and semantic PPA. They are having a frontotemporal lobar disease pathology, as you see in the paragraph. FTLD tau, which is the BSB and CBD, and FTD TDB, which is the semantic variant. And in the first type, they usually have people with behavioral variant FTD, younger age of onset, and usually they have also a caudate atrophy in the MRI. When we talk first about behavioral variant FTD, 60% of patients present between 45 to 64, so it's very early onset of presentation. Prevalence is 15 to 20 per 100,000, 12 to 20% of all patients of degenerative dementias, and 40% have family history. Progresses most rapidly from time of diagnosis, 3.4 years from diagnosis to death. 20% shows Alzheimer's disease pattern of inheritance and has strong association with ALS. So if you have suspicious patient with FTD or behavioral variant FTD, please do or check for C9 or F as it has link to ALS. Loss of sense of humor, altered social decorums, and usually they are very, they come in early manifestations, as we see here in the criteria. Usually they have early behavioral disinhibitions, apathy, loss of empathy and sympathy, early preservations, stereotypic behaviors, hyperorality, and when you look to the MRI, they have frontotemporal atrophy. And this is the second slide, as you see, comparing behavioral variant FTD with elderly people. As you can see that there is a frontotemporal atrophy. Treatment, there is no current effective treatment, but you are only treating the behaviors. Medication currently used are most off-labels with limited evidence. So when we come to the treatment of cognitions, no role of cholinesterase inhibitor in treatment of TD. Memantine might worsen the cognitions. And treatment of behaviors, we are going with SSRIs to treat. Citalopram and fluoxetine have been shown in small open-label series to improve disinhibition. Clomipramines also help in obsessive-compulsive behaviors and hoarding behaviors. Treatment of behaviors also, trazodone demonstrate efficacy to improve irritability and depressive symptoms in small randomized double-blind placebo-controlled trials. So the only one, the trazodone is a good choice for people with FTD. Evidence of using antipsychotic in FTD mainly comes from small case reports and series. Risperidone and aripiprazole were found to be useful in case report. Olanzapine was shown to be in open label trials to improve delusions and caregiver stress in FTD patients. Quetiapine was observed to improve agitations. So when we come to the second type, which is primary progressive aphasia, has a three type. Logopenic, which has Alzheimer pathology, so I'm not going to talk about logopenic. Semantic and non-fluent, which are considered FTLD pathology. So in non-fluent, it's from its name, non-fluent. Patient is verbally non-fluent. We usually say non-fluent when patients is not able to talk, like making 3 or 4 words in his spontaneous speech. So it's a heterogeneous presentation. Why heterogeneous? Because people with non-fluent PPA, they usually presented in a 2 different way. Whether agrammatisms, patients is having problems with his non-fluent speech, or he can come as an apraxia of speech. So if you have 2 patients, so he might come as an apraxic speech, or he can come as a agrammatism speech or non-fluent. So it's an heterogeneous presentations. But usually their comprehension initial of disease is good. They have good comprehension. But on MRI, it shows a left posterior frontoauricular atrophy. In semantic, PPA is different. Semantic PPA, the problems with comprehension, especially towards the name and toward the single word. When you are talking to people with semantic PPA, they usually, if you talk with one sentence, he might not understand you. But when you keep talking, he might understand you. So people with semantic, they have problem with a single word comprehension and naming difficulties. And they are homogeneous presentations. So if you have 50, let's say 50 patients with semantic PPA, they usually come same. They don't differ as a non-fluent PPA. So it's less likely to have an Alzheimer pattern of inheritance. But you know, in semantic PPA, there is a small group that the pathology is due to Alzheimer. So if you have patient with suspicion of semantic PPA, it's okay to try with the medication of Alzheimer. He might benefit because there is a small group of them having Alzheimer pathology. 15% of semantic PPA have history of autoimmune disease, so it's good to look for thyroid, especially thyroid. Left-handedness is more common in semantic PPA, and we don't really know why. And when we look to the criteria, which made by Professor Groni Timpani, there will be 2 problems: impaired frontation naming and impaired single word comprehension. And their speech is good, so they spared the speech production, so they are fluent. They are fluent in their speech. They have surface dyslexia and dysgraphia, so they have difficulty to read, reading difficulty, and the repetition is normal. So repetition usually impaired in the logopenic type PPA. So this is the temporal or semantic PPA MRIs. As you see that there is a temporal atrophy. And here is the SPECT scan. If you can see the third line, in the third line, you will see that there's a hypometabolisms in the left temporal lobe. So that's indicative of semantic variant PPA. Managements, there is no cure for semantic PPA, unfortunately, but as I mentioned that it's okay to use Alzheimer medication, reverse cholinesterase inhibitor, because there is a small group, they have Alzheimer pathology. In the vascular cognitive impairment, vascular dementia is second common cause of dementia in the United States, and it's 15 to 20% of clinically diagnosed dementia, and perform worse in the executive functions compared to memory functions. So we don't usually see pure vascular dementia. What we usually see is a mixed type, Alzheimer in addition to vascular. Okay, so here where you have vascular cognitive impairment and dementia, there is mild neurodegenerative disorder and major neurocognitive disorder, which is vascular dementia. Post-stroke, the patient will have dementia after the stroke, or subcortical vascular ischemia, where patient will have small infarctions to specific areas in the brain that lead to memory impairment, and multi-infarct, where patient will present with stepwise presentations. And mixed type, when the patient's coming with, in addition to stroke, he has Alzheimer's, specifically in elderly people. So when you look here to the MRI, as you see that there is an posterior BSA stroke, and it is affecting even the hippocampus of the left side, and that cause memory impairment. So that's the area where the people will have memory issues in the stroke, usually angular gyrus, thalamus, caudate, putamen, basal ganglia, and BCA, because in the posterior cerebral artery infarctions, it has a small branch towards the hippocampus, and in the anterior cerebral artery territory as well. So those area where the patient, if he have a stroke, even if it's small, can cause memory issues. Thank you.